I recognize a couple of names. We're going to do a really brief introduction to our staff members to give you an idea of how this program is going to work today. And then afterwards, we're going to go in and discuss a little bit about the All of Us research program. And after that, we're going to actually listen a little bit to a discussion of epidemiology, and then y'all are so welcome to submit questions to the Q&A button as this is kind of going. And at the end, we'll take the last 10-15 minutes to have a more informal chat and Q&A session with our panelists today. So once again, I would just like to reintroduce everyone. And as a reminder, go ahead and put your name, and if you're a community member, AHEC scholar, or an organization has sent you here, go ahead and put that in the chat as well, just so that we have a record of people who have attended today. With that being said, first of all, I would like to introduce Dr. Gabriel Benavidez today. He is a professor at Baylor who specializes in the public health department and works in epidemiology. He is actually also a member of the AHEC board, so we are really honored to have him today. We also have Ashley Bearden, who is a two-time graduate from Baylor as well. She is also actually been working in the epidemiology field during the COVID-19 pandemic, and she's the executive director of AHEC. So we see her a lot, and we're happy to have her here. And finally, we have Megan and I. Megan focuses on the All of Us research program. She is a fellow program specialist. And I am Morris. I use any pronouns, and I help organize these events. So super lucky to have all of y'all here today, and thank you so much. With that being said, Megan, do you want to go ahead and do the All of Us intro?
Yes. So we have a QR code on the screen. We'll show it again at the end, but I do invite you to go ahead and scan that and learn a little bit of the program as I go. Next slide. Next slide, please. Next slide. Okay, so before we begin, I want to start by acknowledging we are partners with Pyxis Partners, and they are funded by the National Institute of Health. And these are some key terms and definitions that are central to all of us. Next slide. Okay, so what is the NIH All of Us research program? So the All of Us research program is a historic effort. It is a large research data set, the largest of its kind, and it'll last 10 years or more. So that's the longitudinal part. This will allow researchers to study health over time. And we hope that at least 1 million or more Americans will join in the All of Us program. All of Us aims to engage a community of participants that reflects the full diversity of the United States. And this really includes participants that have been currently left out of health research. To be frank, health research has kind of been by the white man for the white man. So this program is really accelerating the diversity in research. We welcome participants from all backgrounds, all walks of life, all regions of the country, and who are both healthy and sick. So people who join will provide different information. So taking into account where you live, your health, your habits, your genetic information, and all of that will be taken into account by researchers to study what affects people's health. So rather than using a cookie cutter kind of one size fits all approach, All of Us is part of the broader precision medicine initiative. So this is to take into account your unique makeup as we change health. So this will ultimately produce more accurate diagnoses, earlier detection. The program will even take into account things like pharmacogenetics, so how different drugs will work different for different populations. And so this is accelerating all of that for precision medicine. Next slide. So these are some of the questions that this resource may help answer. And All of Us is not a disease-specific data set. So rather than creating kind of a database of information on just one disease, it's taking into account all of those things I was talking about to inform thousands of studies and cover a variety of health conditions. Next slide. So some of the innovative aspects of All of Us, I'll start on the right here. All of Us is informed by this quad diversity model. So taking into account the full diversity of people at a scale of 1 million. So smaller scale studies can't learn as much to inform kind of the future of health. And so this is a very large study. It's taking into account, people who are healthy and sick. So that health status, including different geographic regions, right? People from all over the country, and taking into account different data types. So this is fully informed beyond clinical, genetic health information. It is compiling studies that are asking you questions on your mental health, your behavioral health, things like your socioeconomic status, how where you live impacts your health. All of those things are taken into account in this. And there's a huge focus on participants as partners. So if you decide to enroll in this program, you have full access to what is happening with this data, what people are doing in the researcher workbench, that more nuanced part of the data set. And then you also get to give input to the program to have choice as well. So if you decide at any point you don't want to be part of this program going forward, that is fine. And the program cares a lot about what you think with what they're doing. And this is a resource for all. So as all of your data is collected and you enroll in this program, it all goes into a broadly accessible data set. And so there is 3 different tiers of access. So for the everyday participant, you can go online to the research hub, and there's going to be very curated bits of the data that's being done with your participant information. And then different researchers from academic, nonprofit, and healthcare institutions can have a more nuanced look at some genetic information, some health information, and ask broader research questions or more nuanced research questions. Those are also fully accessible to see what people are studying. So you can look up every active workbench project, and there's even comment features so that you can communicate with the program, even if you don't have a research background on what's being done. Next slide. So what is the promise for participants? So this is an opportunity to improve the health of future generations, right? Moving from that cookie cutter one size fits all approach to making sure that every population, every person on an individual level can have healthcare for them. It's a chance to learn about your own health. So you get a return of results from the program. You can get your genetic information back, your ancestry profile, just basic health markers. Things like those pharmacogenetic reports, seeing how your specific DNA will interact with different drugs on the market. So if you're getting treatment for something, you can share with your doctor that certain things will work better than others. And it's an opportunity to ensure that your community is included. So specifically, if you are from a population that has not previously been included in medical research, this is an opportunity to make sure that you're at the table and that in the future, like the full diversity of the United States is changing and shifting so that our healthcare can actually benefit as our country changes, all the people that live here. And there's also a chance to become part of other research opportunities. So this is with the National Institute of Health, and you do have resources to connect with them to learn what else is going on if you really enjoy this project. Next slide, please. So the current protocol, if you want to enroll, that QR code that we put up at the beginning, I'll have a couple slides down. You will fill out to enroll in the program, create a profile. You will fill out some consents. You can choose to authorize or not authorize your electronic health record. If you don't know how to access that, it's fine. The program can look it up by your social security number. And then there's some surveys with all different types of information, asking about those things, where you live, things that impact your health, all of those sorts of things. There's about 6 required surveys with more coming every day. I think there's 10 total right now. And then you could be invited to provide your physical measurements. And then if you elect to get DNA results back, you will also be providing a biosample. So that's a blood and urine sample And then the program also provides Fitbits for some regions. In ours, they're not currently providing Fitbits, but there is a way to elect to share if you have like a wearable device, sharing all of that information also with the program. Next slide. So what is the promise for researchers? So I want to start by saying if any of you here are from schools, if you're a high school student, a college student, any level of interest in research, this is a resource for you. It is totally free and accessible to different institutions. So you have to make sure that you get a registration agreement in place, but most universities have those in place, and I can give you a resource to look up whether you have access to that. Or provide some help so that you can get access. So this is an opportunity to save time and resources and really accelerate research to help improve health. If you have any type of disease in the background, go back to the previous slide. If you have any pause on getting into research because you don't know how to analyze data, there is options in the workbench. Once you get in there, there's really clean and curated data, and then there's some more robust analytical tools that you can use, and there is a data research team to help walk through those. This is also a collaborative tool if you want to invite people into your workspace or see what other people are doing. And currently we have 8,650 researchers with almost 750,000 people enrolled. The program really wants more researchers. We want a bigger perspective on the data that we have. And so this is really, if you're interested in research, I really want to talk to you. And then next slide. So there is an opportunity coming up in April. If you're not currently a participant in the program, or if you have any kind of inkling to get into research, the All of Us Researchers Convention is free to access, and all different levels of researchers, high school, college, very well-versed researchers will be sharing what they're doing in the workbench. And it's an opportunity to get inspired or reach out and collaborate with somebody. Next slide. So this is where we'll end today with the All of Us program. This is going to link you to a website to learn more. If you want to enroll, there's the option to enroll. And I will throw my email in the chat. If you are at all interested in the Researcher Workbench, please reach out and I would love to connect with you.
All right, thank you so much, Megan. Once again, I would like to reintroduce our two speakers for today. We're going to have Ashley Bearden and Dr. Gabriel Benavidez talking a little bit about how epidemiology affects underserved populations. And all right, you've already got your slides up.
Sorry, I was muted. All good now? You guys can see my slides?
Yes, we can.
Okay, perfect. So I was just going to start off with, a little bit about me first. I was one of those high school kids. I had no idea what I wanted to do finishing high school. So I actually went the community college route. I got an associate's degree in health education. I was playing football at the time, and I got a scholarship to go to school in Montana, and I ended up finishing up my undergraduate degree in Montana with a degree in health sciences, where I was kind of focusing more on, traditional health sciences, understanding anatomy, physiology, the biology of the body, because that's what I was really interested at the time. But then I really started understanding some of the social determinants of health, some of these concepts I had never heard of before. And so that really sparked, a big interest in me to really learn more about how the health of people can oftentimes be influenced by factors outside of our control. So that really led me to the public health route. And I actually came to Baylor as a student several years ago and was in our community health education program. So I was here at Baylor as a student to finish my MPH degree. And then while I was there, while I was here at Baylor, I started working on some research with some of our epidemiologists here in the department at the time, and I just kind of got that bug for how to quantify disease and how to measure disease, to really develop evidence-based information to generate for policy makers and stakeholders. And so I knew that's kind of the route that I wanted to go, was the epidemiology route. So then I went to the University of South Carolina and did my degree in epidemiology and biostatistics. I was also in an NIH fellowship while there, which was focused on an interdisciplinary education, which really complemented kind of the education and training that I've already received. And so after completing, my PhD, I'm now back here at Baylor University as an assistant professor. But while I was at the University of South Carolina, I started working for a center funded by the Federal Office of Rural Health Policy. And that's where I started doing a lot of this work and trying to understand rural health and rural disparities and access to care, and how access to care really impacts population health. And so I remain an affiliate faculty with this Rural and Minority Health Research Center out of the University of South Carolina. So this is kind of a little snapshot of where I grew up. I was born and raised in a small town called Woodlake, California. It's in the Central Valley of California, a very agriculturally dominated region of California. As you can see, there's a small, a number of houses in the middle. That is my entire town where we live. The closest hospital is about 30 minutes away. The closest level 1 trauma center is over an hour away. If people get in a car accident here, they're medevac all the way. A helicopter has to come out. But this is what I grew up. This was my normal. These are the things I experienced. Very low income region. Many of the people that live here are immigrants coming to work in the fields. But I knew no different growing up. This was my normal. This was what I experienced. And it wasn't until I was in my master's program, in my PhD program, that I really started to understand some of the things I experienced growing up, having to drive 30, 40 minutes to go to the doctor, not having a primary care physician, not going to the dentist regularly. I thought those things were normal, not just the fact that I was poor or my family was poor or my community members were poor. Those were all normal to me. And so it wasn't until I was studying in my MPH and PhD that I realized these are things that impact people's health. And I really wanted to understand how to quantify these measures. So I classify myself as a social epidemiologist. And so I think a social epidemiologist differs from a traditional epidemiologist, where factors like your socioeconomic status, the economic and political environment from which you come from, your cultural factors, those are the primary concerns and primary variables that I'm interested in. I think a lot of traditional epidemiologists, those are auxiliary variables, those are secondary variables that people look at, but these are the primary factors that I like to study, and I like to understand how these factors impact people's health, because these are often factors that are outside the control of the person. People have no control over where they live. Most of the times, you typically live where you were born, and that's the same cycle continues. Your parents live there, so you live there. Your future kids will live there. So I'm really interested in understanding and exploring the impact of these social inequalities and socioeconomic status, whether that be education, employment, and all these other social determinants of health, and how those create and manifest in health disparities throughout the population. And so I think it's important first for me to describe what a disparity is. And so this is a Merriam-Webster definition of a disparity, and it's defined as a noticeable, usually significant difference or dissimilarity. But I wouldn't classify all disparities as problematic. These aren't just any difference in the population. Some differences we expect, some differences in the population, for example, across different age groups. We wouldn't expect the prevalence of or incidence of hip fracture among 80-year-olds and 20-year-olds to be the same. It's a disparity, but it's not a disparity that we're concerned with. It's something that we expect. What I'm really concerned with and what I focus in is in these disparities that are outside of biology, outside of any natural reasoning why we would expect that disparity. And we do not, from a genetic level, most of us, all of us humans are like 99.9% the same. There are very few diseases that have a predisposition just because of your race, just because of your income, just because of your education. But when we start looking at the data, we see those differences throughout those strata of population subgroups where we shouldn't see those strata. We should see equal distribution of disease, but we don't see an equal distribution of disease. And so health disparities are preventable differences. They're differences that happen because of systemic issues, whether these be burdens of disease, burdens of injury, people experiencing violence, or just opportunities to achieve optimal health by what I call socially disadvantaged populations. And I use socially disadvantaged populations because, I know we talk about underserved populations, but I like socially disadvantaged populations because I think it really targets and calls out the root cause of these issues. These are disadvantages because of where you're placed in society, and how we as a society collectively have placed people, whether indirectly or directly. We as a society place less value on people of color, on people who are poor, on people who have lower educational status. And like I said, it's not direct. I mean, perhaps we don't do it directly, but it happens indirectly in society. And for us to combat it and to call out these issues, we have to acknowledge that they exist. And so that's what I do in a lot of my work is I acknowledge that these issues exist in a population, that they're unjust or unequitable, and we have to identify them to do something about it. And so I want to talk real briefly about some of the work, specifically one study where we do look at some of this work. And so to really start some of my work, I operate under two big, not big assumptions, but two primary assumptions. The first assumption, to start my work is I don't believe that disease is random. A large portion of human disease does not occur at random. I have to acknowledge that there are factors within our society, whether that be our economic environments, our diets, our socio-political environments, that either increase or decrease the likelihood of us getting disease. And the other assumption is that we can identify these factors, that they can be systematically investigated and identified. And we can do this through the use of epidemiology and epidemiological methods. And so acknowledging that these two assumptions are true, I can go about my work and understanding this non-random distribution of disease using epidemiological methods. So one thing that a lot of us do, I know every epidemiologist today focuses in some aspect, mostly of chronic disease, because that's the biggest issue facing kind of the United States today. 100 years ago, we were concerned with infectious disease. I know the COVID-19 pandemic really brought infectious disease back to the forefront of American minds, but still the most dangerous and biggest burden that we face as a population is dealing with chronic disease. Almost half of the United States deals with at least one chronic condition. What we've seen is in many studies, many researchers and epidemiologists have done studies on different socioeconomic factors, whether they be education, income, and examining the correlations between individual level types of chronic diseases. But our team and some of the work that I wanted to do was to look at how interconnected social disadvantages is with chronic disease in general, mainly because someone who suffers from one chronic disease likely suffers from multiple chronic diseases. And oftentimes it's always income and education that are the two factors looked at, but there's so many other factors that define our social status and where we are economically, like whether we receive welfare benefits, where we live, how, the value of our home, our employment status, uninsurance, having a vehicle. All of these contribute to our ability to, be healthy or not be healthy. But those are factors that are not often looked at or studied. And so what we did is we wanted to really understand these multiple level factors with chronic disease in general. So we took data from the CDC. It's called Places. It's a Places data set, and we're able to get prevalence estimates of chronic disease at the zip code level. And then using a variety of different data sources, I was able to collect information on where healthcare facilities are at in zip codes, the different rates of uninsurance, different rates of unemployment, income status, people's home values, the percent of people foreign born in a community. And so what we did is we created this measure of chronic disease burden. We looked at 10 different chronic diseases. And we compiled them into one score. And so what this score did is it identified those zip codes that had the highest burden of chronic disease and those that have the lowest burden of chronic disease. And the score ranged from 0 to 20. 0 meant in any of the 10 chronic diseases that we looked at, this zip code had, some of the lowest burden of chronic disease in all 10 of those categories. A zip code that was scored 20 had the highest burden of chronic disease in all 10 of those chronic diseases that we looked at. And so one of the things that we wanted to do was map it. Are there any geographical patterns that we're seeing in the data? And so what we did is we mapped this data. And so you can see, sorry, I gotta move something on my screen. What we see is this is a choropleth map. What we see is the lowest color is those zip codes that have the lowest prevalence of this chronic disease burden. And the darkest color, this kind of really dark maroon, is those zip codes that have the highest burden of chronic disease. And we do see it's a very noticeable geographic pattern that a lot of this heavy burden of chronic disease is concentrated here in the South. And so what we wanted to do next was to do an analysis to examine whether these are statistically significant clusters of chronic disease, to examine whether these places are similar to each other and whether they're all clustering close to one another. Are there clusters of high chronic disease in one area and a cluster of low chronic disease in one area? Right here, we're just mapping it. We don't have any statistical analyses to show are these statistically significant clusters. And so what we did is we did what's called a hotspot analysis. And so we were able to identify with this hotspot analysis that yes, basically the entire southeastern region of the United States is a statistically significant hotspot of chronic disease. And so the cold spots are statistically significant clusters of low prevalence of chronic disease, so really healthy populations. And so I don't have them titled, but what we can see is throughout much of this region, this is Georgia. This is the Atlanta metropolitan region, a significantly cluster of low chronic disease. And we would probably assume there's a lot more people with higher incomes, higher paying jobs living in this Atlanta metropolitan region. Here in Texas, we see kind of the same thing. This is the Houston region, the Dallas-Fort Worth region, and some of those Austin regions. We see kind of throughout the United States, those statistically significant clusters of where there's low chronic disease prevalence typically are located where there's places of high metropolitan, heavily populated areas with people with higher incomes. So then what we wanted to do was also look at some of these zip code characteristics of disease burden. And so this is where I was really interested in to look at not just the traditional variables that we typically look at to examine the associations between sociodemographic and economic factors of chronic disease, but maybe some non-traditional variables. So here on the left-hand side, we have a table. These are the zip codes that have the lowest disease burden. So these are the healthiest zip codes. On the right-hand side of the table, we have those with the highest chronic disease burden. These are the least healthiest zip codes. And so again, like I said, we see an age difference. The healthier zip codes are on average younger. We expect that. We expect to see that kind of disparity because as we age, we're more likely to deal with disease. So that wasn't as concerning of a finding. But then we start to see traditionally what we would see if we were looking at individual chronic diseases, we're seeing the same thing when we have this kind of composite chronic disease score. The healthiest zip codes had an average median household income of $74,000 versus the least healthiest zip codes had a median household income of $40,000. This one was a variable that we were really interested in to look at was the home value. This data was from 2020, so the home values have definitely changed since then, but I think they would still apply today. In the healthiest zip codes, those with the lowest chronic disease burden, they had a median home value of $258,000 compared to those in the highest chronic disease burden, a home value of $91,600. And I think this is especially important to note because when we start thinking about home values, your home value is definitely associated with what your neighborhood looks like. You're probably part of an HOA, there's a park, there's playgrounds, there's lit walkways, safer neighborhoods to walk, and it's easier to be physically active in those areas. So I think this is a notable finding looking at the home values. We find the lowest burden, the lowest chronic disease burden, so the healthiest groups also have a lower rate of uninsurance compared to those with the highest chronic disease burden. Again, this is an issue because these people with a heavy chronic disease burden are going to need probably the most healthcare, and they're more likely to be uninsured. They're also, these zip codes have a lower prevalence of owning a vehicle. The healthiest populations have a low prevalence of non-vehicle ownership compared to the highest chronic disease burden zip codes. There's a higher prevalence of non-vehicle ownership in these populations, which just causes travel barriers, whether that's to get to the gym, to get to grocery stores, to get to doctor's appointments. There's more barriers in this population, higher rates of unemployment in the heavier disease burden group, and then higher rates of minority residents. Here, I showed there's about 2 times greater prevalence of Black residents in high chronic disease burden neighborhoods. And so the second portion was from an equity kind of lens, looking at the distance to the nearest healthcare provider. So we were able to calculate the geographic distance to the nearest healthcare facility to that zip code. And so we looked at FQHCs, ICUs, ERs, and the nearest pharmacy to that zip code. And so this really stood out, and all these are statistically significant differences. So when we looked at the lowest chronic disease burden zip codes, these are the healthiest again. Their nearest distance to an FQHC was about 4.6 miles, to an ICU was 5.6 miles, to the nearest ER was 5.3 miles, and to the nearest pharmacy was less than a mile. But when we compare that to the zip codes that have the highest chronic disease burden, we see drastic differences. Those the nearest FQHC to a highest chronic disease burden zip code was 8.7 miles. To get to an ICU was 18.2 miles. To get to an ER was 14.6 miles. And you can imagine that this was probably a big issue during COVID, because this highest chronic disease burden group was most likely to experience severe COVID infections, and they're the furthest distance from the care that they need, ICUs and ERs, and pharmacies, 8.8 miles on average, the distance to the nearest pharmacy for these heavily burdened zip codes. So what are some of the implications of this work? We know a lot of things in public health. We've studied them. We know them. Two of the big things that we know for sure. We know that eating healthy, nutritious foods are good. We know that. We don't need more research to tell people that eating healthy foods are good. We know that. We also know that physical activity is good. We don't need more research to study if physical activity is good for your health. We know that. What we struggle with today is, how do we get people to do these things? How do we get people to eat healthy, nutritious foods? How do we get people to do physical activity? And so one of the questions that comes up is, basically, when I think about it, is how do we combat chronic disease when the people in communities that are burdened the most by it are so disadvantaged? These communities are just, and the people are just really fighting to survive day to day. They're concerned with paying their bills. They're concerned with feeding their kids. They're concerned with just keeping their job. They're concerned with just basic elements of survival, that when it comes to eating, some food that they bought at Whole Foods, they could care less, because that's not important for that population. When it comes to having free time to go to the gym, these populations often don't have free time. Many of these populations are just fighting to make it to the next month. So it becomes a big challenge. Is, we know the things that would help these populations, but how do we get these people to be able to do it when they're fighting so much just to make it month to month? And so I think a lot of this research shows how these factors of disadvantage are so interconnected with chronic disease. We can't disconnect all these things when we're making recommendations, when physicians are making recommendations for people and how to combat their chronic disease. We have to understand how closely intertwined poverty is with chronic disease. And so I think we really need to move away from recommendations that focus on individual level blame for chronic disease, and we need to move towards acknowledging that many of these issues are systemic, and the only thing that's going to combat them and truly make an impact on people's health and lives is higher level, systemic level policy change. Because without that, I just think we're just going to continue spending more money without really significant results. A lot of what we need is people advocating for significant policy change to really drastically reduce poverty, which will reduce many of the barriers people experience to trying to live good, healthy lives. And I think then we'll see a significant reduction in the burden of chronic disease in the US population. And that's all I got. I added my email, so if anyone wants to reach out to like get the paper, I'm happy to send it to you. Or if anyone just wants to reach out for any other reason to talk about some of this stuff, I'm happy to chat. I also just want to acknowledge the Rural and Minority Health Research Center. They're out of the University of South Carolina. They do a lot of good work. So if any of you are interested, please feel free to check them out, or I can point you in the direction of other researchers at that center who do really good work.
Awesome. Thank you, Dr. Benavidez. So what we're going to kind of pop into now, I'll do a quick introduction of myself. I am not going to go nearly as in depth as Dr. Benavidez did, just because I think that the conversation that we can have around some of the research that he's done, the research that he's looking to do, and then some of the practice-based things that we do as both Waco AHEC and also working with federally qualified health centers is more of the important conversation that we can really have today. That'll be beneficial to, I think, most of the people that are on here. So looking at who I am Ashley Bearden. I am the Executive Director of Waco AHEC. For those of you that do not know what an AHEC is, it is an Area Health Education Center. As the Waco AHEC, we serve an 18-county service region, and we are hosted here at Waco Family Medicine. So the purpose of an AHEC is to work and serve rural and underserved populations. So that's one of the big reasons why we wanted to bring in Dr. Benavidez, because of his past research and current research, working with rural populations and the insight that he has into that. So where did I kind of start, since Dr. Benavidez gave us that opportunity as well? So I came to Baylor for my undergraduate degree, where I got my Bachelor's of Science in Health Science Studies, and then I also got my minor in Business Administration, thinking I would never really use that kind of thing because I was planning to go into the major healthcare sector, not thinking of business at all. I then segued and ended up getting my master's in public health also at Baylor, which then kind of led me to staying here in Waco. When I was in my master's program, I was much more focused on a global health epidemiology level. I did a lot of research looking at the rural and urban differences between treatment status, specifically in pediatric populations in Uganda, looking at surgical differences specifically. While I was also in my master's program, we did practice-based work in Brazil, not really kind of like the epidemiology level, but just kind of a different kind of lane that I've taken and perspectives that kind of give me what I am today. It kind of shaped me the professional that I am. And then during COVID, I was approached to lead part of the state response and assist with that as an epidemiology lead for DSHS. And I felt that during that time, it was kind of a responsibility that I had as a public health professional, someone who had been trained in the field, to kind of take those steps to step in and to assist kind of our communities as we were going through that. So during that time, I oversaw a team of around 50 looking at case investigators and contact tracers who were reaching out into the community, going and having the conversations with the individuals that had COVID. And during that time, when it was still kind of all the chaos, really during the height of the epidemic, it was very interesting to kind of see how all of those conversations were had, because just like Dr. Benavidez was saying, when you're looking at disadvantaged populations, you were seeing such a significant difference in wealthier neighborhoods or wealthier populations and communities versus looking at some of our other populations. So I just remember during that time, we would have tons of conversations and individuals that were along our border towns. So looking at like Brownsville, El Paso, and just the increased rates that they were seeing, and then also just how it was negatively impacting their community more, because you have multifamily households, multi-generational households, and just the difference that you would see from like a Brownsville versus a Waco. So I think that's a very important thing that I learned specifically during the pandemic and why we worked through that. So that is really kind of all I want to jump into about myself before we kind of get back to some of what Dr. Benavidez was saying as well, and kind of linking it all back to the All of Us research program as well, and then the possibility to getting young researchers involved, kind of increasing epidemiology and the knowledge of what epidemiology is in the field, because so many community members and just individuals think that it's like skincare, which is something that we really need to change in the greater population. So Dr. Benavidez, if you want to pop yourself off mute, I know that both Morris and Megan will be asking us some questions as well as we go through this. But one of the things that we have talked about in the past, and kind of like looking back to COVID, was the response that you had with your family at that time, being kind of from your more rural town, and especially like with your grandfather. How do you think that experience, because you were getting your PhD at that time, how do you think that experience helped shape you into the researcher that you are now, helping your family through that kind of time?
You know, I think, especially during COVID, I think like you said, I kind of felt like I had a responsibility to do some of this work. Um, and that's what it felt like. I was in the first year of my PhD when the pandemic hit. And I'll be honest, I knew nothing, really nothing about epidemiology compared to what I know now. But I was seen as the go-to person for people in my town, for people, that my parents grew up with, because they don't know anyone else like me. So I became the de facto expert in anything and everything that they had questions about. And I would have to tell people I have no idea. Um, but it felt like I had a responsibility to provide information to people that sought this type of information. And so just having kind of that example of dealing with COVID, now I feel like I have a responsibility to my community and to people that look like me, people that were raised in communities like mine, to do this kind of research because we research what we know. And every researcher is going to do that. They're going to research things that they know or things that they're familiar with. I'm familiar with rural populations. I'm familiar with low income populations. I'm familiar with Hispanic and minority populations. So I can study them with insight into those populations. And so I do. I feel like I have a sense of responsibility because I get to sit, at a table where I have a little bit more power and I'm more of I get to create the evidence that decisions are based off of. I feel like I do have a responsibility to do good research and bring up some of these and acknowledge some of these issues in these communities.
And that kind of you speaking to researching what you know, and researching the populations that you know, that's actually one of the big pieces that all of us actually pushes for both the researchers and the participants. So one of the main pushes for the All of Us research program is to make sure that we have representative researchers, so that the populations that have been historically underrepresented in research and in medicine are having that opportunity to have that voice heard from both kind of like that internal perspective, but also the greater perspective. And that's kind of looking even to things like the Tuskegee study, that happened with the syphilis study, looking to Henrietta Lacks and some of the mishandlings of pieces that happened with her and her kind of literally her body when they used pieces of it. Yeah. So what do you think we can do to better shape our young researchers, to make sure that they both use their background in what they know, but to also expand that into kind of asking those questions to be comfortable being uncomfortable?
Yeah, I think a lot of it comes from trying to recruit a diverse pool of candidates. Um, it's hard to try to train someone to do research in a population they don't understand. Um, so I think that's where it comes upon, people like us, people in positions of power, is to recruit a diverse pool of candidates so that we can train them to do the research. They already know the populations. They know and they're intertwined with these communities. Maybe they just don't have the research skills to do it. So that's where I think it stems from. It's trying to train a workforce that is representative of the U.S. population. Because I think there is potential for harm to try to put researchers who don't understand these populations to research these populations because you make assumptions. Everything I do is based on assumptions. If you go in with the wrong assumptions, you can inherently do damage indirectly, even if you mean to do well. You talked about some of those, the Tuskegee syphilis study, the Henrietta Lacks. Those people did not believe they were causing harm. They thought they were doing something good, but those were incorrect assumptions that they went in with. And so I think it really stems from trying to recruit a diverse student population, a diverse training population, so that we recruit people that look like these populations to go back into these populations so that they can study the people that they look like. Um, because I think there is potential harm in trying to put people who don't come from these populations to study these populations because you can make a lot of incorrect assumptions about these populations.
Absolutely. And that reminds me of a conversation that we actually recently had, looking at some of the research that some individuals had done, and they weren't from a specific population, and their role was literally to observe a population, and they changed what they were doing in that population because of those individuals that were conducting that research and that observation. And so the internal validity, all of it was very much skewed based off of what was going on.
Yeah.
So when we're still kind of looking at research and really kind of keeping it on the subject of all of us at the moment, I know that you haven't conducted any research or done any data analysis in the workbench or in the hub yet. But from what you have seen, do you think that a platform like the All of Us research program, the workbench, is beneficial to get us going in the right direction for this type of research and change that we want to see?
Yeah, I think it is. A big reason is because, I'll use, Native American and American Indian people as an example. They are so understudied because they are such a small percent of the US population. So many researchers don't even bother to collect data on some of these individuals. And oftentimes we'll just aggregate, American Indians, people with Asian descent, people with other forms of descent. So primarily you'll see categories of white, black, Hispanic, because those are large populations. And then we kind of just lump everyone else into one category. You can't understand American Indian people if you've lumped them all into one category. I know many Native American and American Indian researchers who would love to do the research on their population. There's just no data for them to use. I think the All of Us platform gives them the opportunity to have high quality, valid data. For research, there are researchers, there's not a ton, but there are researchers in many of these populations that just don't have the data that they need. And it's hard to collect the data. So I do think the All of Us research platform, using American Indians as an example, does provide researchers that are from these communities the access to data that they need to study some of these populations.
Absolutely. And while you were speaking right there at the end, I did see a message come in on the chat. I'll go ahead and read it as well. So how do we include homeless or transient populations in the data set? Even if carefully followed and sanitized, there will be more gaps than solid data, right? Yet they have very unique healthcare challenges. So the overall question is really, how do we include the homeless or transient populations in the data set? I'm assuming this is kind of like an in general population. Do you want to hit this one first?
Yeah, I think it's so tough. With everything, there are limits to what you can do, and there's barriers for everything. To be part of the All of Us, to get access to your data, you need to have, a computer or a phone app. And so that's just a barrier for transient and homeless people. Um, yeah, that's a tough one. It's tough to get transient people into any form of research because by definition they're a dynamic population. Their situations are always, changing. They're not in one place. And I think that is a very understudied population just because naturally it's hard to follow that group over time because they're such a dynamic population.
I would agree with you on that, that in getting to that population can be very difficult, but also the fact that in working with certain disadvantaged populations or underserved populations, just making sure that you're doing right by those individuals. I think that's one of the biggest pieces that can sometimes be skewed in trying to pull their data, especially with some of the incentives that researchers can offer to certain populations, then trying to find those, I think that can sometimes make things a bit more difficult. But like you said, with the All of Us data set, it does have to, you do have to have the opportunity to follow these individuals because it is a longitudinal study. And if we are losing individuals to follow up, we don't have good retention there, then we're not going to be pulling the good data that we need. But if they're pulling information in, and I mean, we have organizations in Waco that work with these populations and pull some of that data at a lower level, but a more kind of individualized level as well, where I think that's really where it comes in to be of benefit. Another question is, what role can FQHCs, so federally qualified health centers, play in finding and alleviating discrepancies?
You know, I think FQHCs already serve a massive role in providing healthcare at an affordable or even sometimes free cost. The cost is a major barrier for most healthcare providers. So just the fact that FQHCs exist is already probably the main role that FQHCs play in trying to fill a gap in some of these disparities that people face. Now, the issue is the recommendations that physicians, give. An FQHC can only go so far. They can provide the care, but I think one of the very unique things of Waco Family Medicine is the piloting of and the use of maybe non-traditional intervention methods. As a student, when I was here at Baylor, and I'm sure it's still going on, they had the veggie produce prescription program where they're able to provide people with food so that they can cook at home. The exercise prescription program where they're able to provide a facility and training for people to be able to get access to exercise facilities. Those are two major barriers. Just having access to it is a barrier. And so I think FQHCs expanding that model to other FQHCs is another way that we can help fill those disparities. But just the fact that FQHCs exist is already playing a significant role. And I think Waco Family Medicine specifically is really innovative in terms of implementing interventions where they know we can only do so much providing the healthcare, but we can also maybe provide an exercise facility, and we can also provide produce for people to cook.
Yeah, I absolutely agree. The only thing I would add to that is that FQHCs are uniquely placed to apply and get granted grant funding as well to kind of continue working with these types of programs that you're talking about. So sometimes when you're looking at we're in Waco, so if we were looking at a Baylor Scott and White, they have larger funding cycles overall, but they aren't necessarily seeking out the same type of grant opportunities and have some of those freedoms that come with that. But absolutely. And another question that has come in the chat is, from an epidemiologist perspective, how can healthcare providers, specifically family physicians, to and research personnel better introduce the research concept and the importance of conducting bioethical studies to vulnerable populations?
I think a big thing is more healthcare providers, specifically MDs. MDs are not trained to do research. They're trained to provide care. And so, like I said before, we make assumptions in our research. We make assumptions all the time. And I think the best thing that physicians can do to do, ethical research and asking ethical questions and using ethical methods is to partner with people that are trained specifically to do research. I am not trained to provide care to people, but I am trained to do research. And so I work with physicians all the time, and we complement one another on, I'll do the statistics, they inform me on the clinical care, do my stats make sense in terms of clinical practice? So I think that's a great way is for physicians and PhD or MPH level epidemiologists to work together to complement one another. We have differing skill sets. It's not a competition. I think that's really where I'm very collaborative in my work. I love working with physicians. I think that's one of the ways to do better research is to have a much more collaborative approach to research to complement one another.
Absolutely. And I think that question and then your response to it kind of reminds me back to some of the research that you were talking about earlier when you were looking at the map and the hotspots, and kind of looking at FQHCs in general, and rural populations. So like I mentioned earlier, as AHEX, we work with rural populations. And I know that you might not have done any of this in that specific research, but how do you think that the research that you did there can help community organizations and FQHCs shape some of the work that we're doing? Because sometimes these conversations aren't openly had, and researchers will just post a paper and send it to the journal, and then not much comes of it. So how can we make sure that we're being actionable based off of the type of research that you're completing?
Yeah, so I think again it comes to that collaborative approach. One of the good things, the Federal Office of Rural Health Policy funds 7 centers across the country. I was really fortunate to work at one of those 7 centers. What we do is we part of the stipulation when we get this grant funding to do this research is we not only produce research publications, is we produce policy briefs that are understandable, toned down for the layperson to understand, for a community stakeholder to be able to take to a local organization and be like, this is research. There's a platform called the Rural Research Gateway. That's where all of our stuff is posted, and it's in a simplified manner. We produce it for stakeholders to take to days on the Hill, whether that be on Capitol Hill or their state legislators. um, I think it is hard for researchers oftentimes, just physically where we're located. Most academics are placed in universities, which are placed in urban centers. A lot of us are not located in rural areas, even if we do work in rural research. So I do think it comes from partnerships like this. Me working with you, you are the boots on the ground person. I can only do so much in generating the evidence. I think we all have kind of our lanes. My lane is to generate the evidence and try to advocate for it. But you are the more boots on the person on the ground, and you can take some of my research and advocate for it from a different perspective. And I think really that's where it needs to start is academics, scholars, and researchers getting out of just behind their computer and really working with community partners to advocate for their research and making sure their research is actionable. And so that's one thing I try to do. I try to make sure I do relevant research. I don't do research just for the sake of doing research. I try to make sure my research has a purpose and try to make sure it reaches the populations that I want it to reach.
Absolutely. And some of what you said about it being actionable kind of leads me to my last question that I have for you based off of our time. So the majority of individuals that attend these the Mix It Up series, oftentimes are students or practitioners. So what advice do you have specifically to, I guess, students, to kind of help shape their young careers as they're moving into them, and what can help make them successful?
Yeah, you know what? I think 100% go into what you're passionate about, what you care about. Um, it's it's hard work. It's hard work when you truly come from these communities, you care about them, and you see the policy change is minuscule. It takes a long, long time, and knowing that it's a grueling process. But I think really just going into it with an open mind that you are, whether the difference is immediate or not, you're working towards trying to generate some form of policy change, generate just a small win. I know I'm not going to eradicate poverty, you know, probably over the course of my lifetime. That's not going to happen. But if I can generate, a paper or some studies that help an AHEC implement something differently or help a state government implement something differently, that's a small win, but it's a win for me. And so I think just recognizing a win is a win and take the wins where you can get them is really all we can hope for sometimes.
Absolutely. I think that's a really good kind of message to end on, especially for public health. So a win is a win. I will toss it back to you, Morris, if you have any questions, or anything to kind of pose as we finish.
Awesome. Thank you so much, guys. So once again, I want to thank everybody for coming and our panelists for actually participating today. Absolutely wonderful to have all of you. If you have any questions or you want to reach out to either of us, ask more, engage more, please follow us. We are Waco AHEC. That's just Waco, AHEC. We come up on Google, social media, wherever you can find us. Yes, thank everyone so much for coming, and we of course invite you. You'll be receiving an email in the next hour or so with a link to all of the next ones. We have a bunch of different topics we're going to be talking about, and if you really enjoyed this, the best is yet to come, and the best has already happened. One of the best things we promise here. So have a great day, everyone.